Welcome to the Byja radio show. I'm your host, Dr. Byron Jasper, and we are recording live from J. Kinba Executive Suites in Baton Rouge, Louisiana, with special production by Becnel Media. All right, we are back, and I'm happy to say that last episode was actually very adult-like, and that's hard to do considering the topic, but the fact that we are still going strong and didn't break character for the most part, I'm happy about that. So welcome back to the Byja radio show. As you can tell, we are happy that we are now, I believe, on episode 15.
15, without being canceled.
Without being canceled, right? And that's hard to do where we haven't had any major outrage or scandal, especially considering the topic last episode. So I'm happy to say we're still going strong. Mm-hmm. And, we're thankful to our listeners and to people who actually tune in and comment, who have done exactly what we asked. They like, they subscribe, they share, they rate it. Yep. They're doing everything. So we're just happy to be here at Byja Radio Show and continue to recording good content that's helpful and educational. But I would not be where I am today in this radio show without my amazing, just overwhelmingly great co-host, Mr. George Becnel, a.k.a. Patient Zero. Patient Zero, how you doing today, man?
You know what? I appreciate that, Doc. And I feel like you're carrying the show. Your back must be tired because you're coming with all this medical knowledge, and I'm just here.
Yeah.
So I appreciate the kind words and the piggyback ride.
It's a yin and yang kind of thing, right? Yeah. It's that balance that you have. You can't have all smart stuff and no plain explanations. You can't have all plain explanations with no smart stuff. So we have to balance each other out is the best way to say it. So I appreciate the fact that George is taking the ride with us again today on episode 15. So today, what are we talking about? Well, as most people would know, the conversation around this potential subject matter is something that people have heard of but don't know really a lot about. So as we're sitting here planning on what our episode is going to be about, number one, we're thinking about patients that we've had, disease processes that pop up, things that come out of the blue and things that come more frequently. And one of the things that pops up all the time that I hear is that people are aware of this but not really aware of what it is, how it works, and all that. And we're talking about specifically the thyroid. The thyroid is something that a lot of people have either been told about, have been diagnosed with a disease of that actual area of the body, but really and truthfully, I rarely hear someone coming in and saying, I know exactly what you're talking about. Yep. It's more of a conversation of, hey man, I heard of this, I know a little bit about it, but I don't really understand. So today we're going to do our best to make sure you, the listener, have a really good front seat of learning how the thyroid functions, what it does, and what happens when it doesn't work. So this is going to be your thyroid crash course to where you all will be hopefully thyroid experts to an extent to where you can at least point people in the right direction if something isn't working the way that it should. So I'm going to start by kicking it over to the amazing co-host, Patient Zero. So Patient Zero, starting off with a question, simple question. For you, in your experience being a patient, obviously being an upstanding individual, how many times has anyone really said to you, I've had my thyroid checked and I know that it's healthy? And I want you to say 0 to 100, 100 being a lot, 0 being little. How often would you say I've had that conversation of someone saying I've had that checked?
You know what? I've had that conversation with family. So I've had that conversation from 0 to 100. I would say about a 10.
10, okay.
Which is I feel like is higher than normal.
Yeah.
But I have another question to throw back at you as my physician.
A question to the question. All right, I like it.
Is my thyroid healthy?
Your thyroid is amazing. Let's start there, okay?
Yeah, because I didn't ask. I never asked before. I don't know.
Yeah.
That's good news.
And the good news about...
That's the Byja Radio exclusive. Patient Zero.
Breaking news.
Breaking news.
There you go.
Patient Zero
has a healthy
thyroid. You heard it here first.
There you go. So I think the big part of that is, as you mentioned, people know about it, have had a conversation, but don't know much else other than I had it checked and it's healthy.
Yep.
Which is great, but the goal is to kind of go beyond that. So what is the thyroid? Patient Zero, I'm going to give it to you to kind of give our listeners a crash course at number one, where the thyroid is. And then, of course, how large is it? How does it potentially function in terms of simple things? Now, if at any point you need to pass the baton back to me, I'll take over. But I'm going to try to give you the floor to give people just some general stuff, because I think people have an idea, but they don't really know all these things. Because I actually had a conversation with a mutual friend of ours who's also a patient, and we had a conversation about the thyroid and what it looks like and where it is and all that. And that conversation was something that kind of put this into my purview of, hey, we probably should talk about this, because a lot of people don't even know these small questions, these answers. So let's start by, again, refresher. Where is it? About how large is it? And what is the function as a whole? Doesn't have to be in the details, but just kind of giving people a sense of what you think and what you know.
So I like this one because I can actually answer this one partially without the notes.
There you go.
So I'm going to give you what I know, and then I'm going to go back and look at the notes and give you the rest.
There you go.
So the thyroid gland is found in the neck.
Correct.
Right?
Correct.
And also it can affect weight loss or weight gain depending if it's functioning less than properly or overly functioning, because it could go either way.
Yeah.
And it also can affect your energy levels depending if it's how well or how poorly it's functioning, right?
Okay.
Now,
what is the size?
So from the notes,
From the notes.
I didn't know that one,
You didn't know that one, right?
but it's cool. I can say it because I knew some stuff.
There you go.
So it is a butterfly-shaped gland in the neck.
Okay.
Right? And
So would you put that as a small, medium, or large gland?
well, considering other glands, like in your skin, considered a gland. No, that's
It's an organ.
It's an organ.
It's
so
an organ.
I would say it's a small gland.
No, I'd say small to medium. It's not huge, but it's also not the smallest, right? So I think it's great that you said a butterfly, because most people know what a butterfly looks like, right? But when you think about that, the only other thing I think you have to always specify when you're talking about the thyroid, you said neck. So when you're, again, medically trained, you have to always specify where in the body something is. We can't just say your neck. We have to say what part of your neck.
It's in the front.
Anterior is the medical term.
Okay.
Anterior neck, right? So it's in the front of the body,
Right.
pretty much right behind the Adam's apple if you're a male, or where the Adam's apple would be if you're a female. So it's a butterfly-shaped gland behind the Adam's apple. That's pretty much the simple place. But if I say it's in your neck, it could be the back of your neck, it could be the side of your neck.
True.
Right? So we always have to specify anterior portion. So
I knew it was in the front.
the front, right? So the anterior gland that sits behind that Adam's apple or Adam's apple area, and it's a pretty small to medium-sized gland. You hit on a very important part, which we'll talk about in a little bit, which is how it functions in terms of if it doesn't function well, or if it does function too well. But what I always tell people from a very general standpoint is the thyroid is the battery of the body. It's very simple in the sense of not the only battery, but it is a battery-like thing.
Kind of like an alternator.
Okay, I'm gonna go yes, but I want you to think about it from a battery standpoint of if your battery works, things work fine. But if your battery is not working well, things start to not get enough power or juice or whatever term you want to use, right? Similar to an alternator, because I see you smiling. You're pretty much like, I know this is right. But if it's also in overdrive, the battery is working too much, it can burn things out.
Right.
So that's the point that a lot of people don't seem to really understand, but it's a simple concept that people can wrap their head around. If my battery in my neck is not working the way it should, I'm going to have problems one way or another. It works too well or it doesn't work well enough. As opposed to saying, well, it's a butterfly-shaped organ that literally does hormones and you don't have to do all that. Just simple like, hey, the battery in the body is not functioning. If it's functioning too well or not well enough, we're going to have a problem. And that's the simple concept of the thyroid. Now, let's go one step further. We talked about where it is. We talked about kind of what it does. We talked about how big it is. Let's talk about how prevalent the disease is when it comes to people in America. How many people would you say have thyroid disease when it comes down to what we see in America? Now, I'm gonna go one step further. Who has more thyroid problems in terms of male versus females? I'm gonna see if you have an idea of the first one. First one, simple, male versus female. Who has more thyroid
I
problems?
would say female.
Okay, is there a logic behind that?
There's no Adam's apple to protect it.
I can't argue with
It
that.
makes sense in my head. It makes sense in my head.
There's no argument. I can't even say No, but at the same time, you got it right.
It makes sense.
Yeah, it's just as simple as it's water wet. That's what I tell people sometimes. So makes perfect sense. But yes, women are more likely to have thyroid disease. So what is the rate that you would say women tend to have thyroid disease? Let's go between 1 and 10. How many would you say?
8.
Okay.
1 and 8.
1 and 8. Okay, so between 1 and 10, 1 and 8. So what would that put it at? It's a math problem.
Oh, like percentage wise?
Yeah.
Let's say 1 and 5 is 20%. 10 is 1 and 10 is 10%.
Yep.
I say 12.5.
Yeah.
Exactly 12.5. That
There you
makes
go.
sense.
Look at you. There you go.
Well, I can do some math.
There you go.
Biology, I was terrible. I can't do. I'm sorry, Miss Wild. Miss Wild was my biology teacher in high school.
You apologizing right now?
Yeah, I was terrible. But like in Coach Levin class for math and Miss Perilou, I was eating that up. I can do some math.
You can do math.
I can't do biology.
I got you. Well, that's spot on. Like I said, you're looking at somewhere between 10 to 15% of people, specifically women, will have thyroid disease. So obviously, if you say, well, I take 100 women and put them in a room, 10 to 15 women have a thyroid problem. That's the simple way to think about it, right? And that's an actual significant number, right?
It's a huge number.
Yeah. So if you're talking to people and saying, well, look, one person has it out of 100, usually you're like, oh, that's not too bad. Maybe 3 people. But when you're starting to get into double digits, that's pretty significant. So that's on the women's side. How many people would you think in America potentially have issues with thyroid disease? If you had to just take a shot into the dark, how many hundreds of thousands, millions of people you would think may have?
How many people got in America?
Too many. I'm sorry. I'm just messing. No, I have no idea because I'm bad at stats like that. But I will say I know we're probably somewhere between, I'd say 100, 200 million easily.
If it's 200 million, I say 20 million.
Okay. Yeah. So I think that's about right. We're looking at almost 10, 15, 20 million people who have the problem where a thyroid's not functioning the way that it should. Last question when we come into stats, and then we'll kind of jump off of the stats side of things. Where would you say we're talking about people being diagnosed with thyroid disease, where you say we have a bunch of people who know they have a thyroid problem, they're getting treated, versus people walking around who think they are just having symptoms and don't realize it's a thyroid problem? And the reason why I'm asking that, I'll tell a story about this whole conversation when we get to later in the show. But I want to ask, how many people you think are walking around with undiagnosed thyroid problems and have no idea?
Yeah, so I'm just thinking the notes say 60%. I think that's low.
You think it's low?
I think it'd be more like 80% of people might have a thyroid issue and don't know. Because if you like the symptoms of a thyroid issue is like you're tired and you might be overweight or you might have too much energy or you're skinny.
Yeah.
Like some people, especially people that's tired and overweight, they might just be like, I'm old, I don't feel like working out, and I'm just fat. Like I don't think that there's any
rhyme or reason
research behind that, or there's any diagnosis, or there's any like, hey, let me go to the doctor and check on this.
Yeah.
You know what I mean? Yeah. So I would assume most of that is undiagnosed.
Yeah, I would say that it is somewhere in my book between that 50 to 60% range, because if a person is engaged in regular care, checking a thyroid is pretty easy. And as we talk more, we'll kind of talk about how it's done. Test? So we'll get there.
Okay.
We'll get there. There's 2 to 3 ways you should check it. But the idea is the thyroid check is pretty easy to do. The problem is most people don't know what it is, so they don't realize how it needs to be treated. As we're going to talk more about what are your symptoms and all that, it makes sense on why treatment is necessary. But if you don't know what it is, it's like if I tell you you have plantar fasciitis and you have no idea what that is, you may not really think it's a big deal because it's not causing too many problems. And if you can function and push through it, well, it's something I got.
Yeah.
But if you don't realize that it's setting up a lot of other downstream effects, and if we don't get this fixed, it's going to cause more problems down the road. It's going to be that domino effect that just gets worse. Most people will never go in and get diagnosed, but when they do and they figure out how easy it is, it's actually pretty simple. So with that, one of the reasons why I think we have a good time of figuring this out is because we have more time to do that. And in that DPC model, we have time to sit down and really talk about what the thyroid is, how do we check it, how do we treat it, what do the numbers mean, and things of that nature. So obviously, I'm going to plug DPC all the time. I always have conversations with different people about direct primary care, from patients and doctors and business owners and nonprofit founders and things of that nature, just talking about why the model works much better than the traditional model, because we have more time to really talk about stuff like this. But in regards to the thyroid, it is something similar to last episode's topic and a few others. if everything's healthy, it's a quick conversation. If it's unhealthy, you need time to really break down what this is, how it works, and how it will impact people in the future. And then, of course, possibly genetically, because it could be something that gets passed from generation to generation. So I do highly recommend the DPC model because it gives you more time to really talk about pros, cons, things that are healthy and things that are not. And if I'm mistaken about that, George, you tell me if your thoughts have been to where if we would have a conversation about your thyroid, you would say, you know what? I feel pretty comfortable having the conversation because I know we have time to talk about it. Or do you think it would be something that's like, well, we got to kind of wrap this up pretty quickly?
Well, I'm very comfortable in the setting, because there's a lot of time. It's more in depth.
Yeah.
Right. Because I have time to ask questions. I have time to, I guess, for lack of a better term, just understand or like challenge you because, again, what I think people don't realize is that a doctor is a resource and you are in charge of your own health. So I shouldn't just, in a short visit, I feel like doctors talk at you and they just tell you what the diagnosis is or what they think and why they think it.
Yep.
And then they leave the room. Where for me, I may, that may not fit. Like you might have an idea, like let's say we're talking about a topic and I'm telling you X, Y, and Z. You might say, hey, this is what I think it could be because of 1, 2, 3. And I'm like, well, 3, I don't have 3. Maybe 1 and 2, but I don't have 3. And we can talk about it more. And I feel like that's provides a more accurate diagnosis. The fact that we can sit there and have an actual conversation because we have time. We have time to do it.
Yeah, we have dialogue as opposed to a monologue where someone's just talking at you.
Yeah, and it doesn't, and it may or may not work. And the thing about, and correct me if I'm wrong, to you as a doctor, somebody who's doing the diagnosis, I feel like you get more accurate diagnosis if you have more information. And I think you get more information by uncovering more, symptoms or having a general conversation instead of speaking at someone.
Right. Yeah. I think partially that, but also you have more discussion. It opens up more things that other people may not have uncovered is the best way to say it.
Yeah.
Right? You may say something that kind of triggers I didn't even think about this because I didn't know that existed, or I didn't know that was in your diet, or I didn't know that was in your family. I didn't know you had that experience because normally we wouldn't talk about it in this much detail.
Sure.
So I think it makes a huge difference. And I think on the DPC side, talking about the prevalence and talking about who's more likely to have a disease and talking about where things are in the body and how it potentially works and functions, it gives people just more information that allows them to feel comfortable about the direction we're going to go in from a treatment standpoint. So since we mentioned treatment, let's get into what are we treating? Because sometimes treatments are for the disease, sometimes treatments are for the symptoms. So we're going to talk about the disease that we may see based on something you mentioned earlier. So you said that there are 2 potential things that the thyroid may have problems with. 1 versus 2. So I'm going to go back to you and I want you to tell me what are the 2 that you would say, when I think about the thyroid not working, these are the 2 directions that I look into.
If it's not working?
If it's not working, whatever that means, what are the 2 directions that you would say you have in a thyroid that doesn't function properly? Which 2 directions do you go?
Well, I would say it's either not working at all or not working well or it's working too well.
Working too well.
So you can either have symptoms of where you're overweight or lack of energy, or you can be opposite where you got all the energy in the world and you may not be able to keep weight on you.
Yeah. So I think you're hitting on some of the symptoms. Let's talk specific. So let's make sure people can attach what your, for lack of a better term, diagnosis is to what is happening. So you just said 1, it doesn't work well and it's not functioning. So what is that called?
Hypothyroidism.
Okay. So say it slowly because sometimes people don't understand.
So hypo.
Okay.
Is if it's not functioning well. So hypo.
Okay.
Hyper, think about like when you were a kid and you had a bunch of energy. Somebody might say that kid is hyper.
Yeah.
You remember those days?
Yeah.
Did y'all say that down there in home?
We would say they were special
Yeah, okay.
or touched.
Yeah, we said that too. But I feel like there was like if a kid was so overactive,
Yeah.
he was hyper.
Yeah.
You know what I'm saying? So if you think of the word hyper is over, it is a lot of energy. It does too much.
Yeah.
So hyperthyroidism is if your thyroid is supposed to be working at a 5 and it's working at 15.
There you go. Spot on. Now, I'm going to help one step further by setting you up. I'm going to throw the alley. Let's see if you're going to oop it. Give me 2 other diseases that phrasing works. And it's not in your notes. Okay. It's not in your notes. I'm putting you on the spot. And I'm putting you on the spot because it's not hard. It really isn't. Medicine is not hard. It's just learning the vernacular, right?
Right.
So you just said hypothyroid, hyperthyroid, right? So what is a common diagnosis that a lot of people in Louisiana have that they take medicine for all the time because their diets are horrible?
That their diets are horrible.
Diets are horrible.
Diabetes.
Okay, that's one. But that doesn't have hyper in it.
It does not.
So what other one does? If you say diabetes, this goes right along with it. Hypertension. Hypertension.
Oh God! Why did I get that? I know this.
You absolutely know this. That's
Hypertension is high blood pressure.
And
so there's hypotension as well.
there is hypotension, which is
low blood pressure.
low blood pressure.
Yeah.
But most people don't get treated for that on an outpatient basis. When you have hypotension, more than likely you're in the hospital,
Yeah.
right? Or you're passing out and something's going on. But it happens all the time. And in medicine, as we talked about last week, when you learn about things like the word itis means inflammation,
Yeah.
you start to learn that when I say something has itis in the ending, you know it's something's inflamed, right?
Yep.
Cellulitis is the skin is inflamed.
Yeah.
That's what it is. Tonsillitis, your tonsils are inflamed. So hypertension, high blood pressure. Hypotension, low blood pressure. Hyperthyroid, high thyroid, hypothyroid. So that's why I was saying it really isn't hard. So as people start to kind of listen, they'll say, okay, I kind of get it. Something's hyper, it's overdrive. As you just said, it's functioning way too well. Versus hypo, it doesn't function at all. And let's now go one layer lower. Hypo, let's go through the symptoms you will see in a person who has hypothyroidism. Or then we'll go over to hyperthyroidism. So you named some, but I want to be as specific as possible. So you said, which ones associate with a hypothyroid? A thyroid that doesn't function well, the battery in your body is not working, and it's not putting out the things we needed to put out. What things will happen to the body when the battery doesn't work?
So
You already said a few, but fatigue, right? Weight gain.
muscle weakness for sure.
Okay.
Constipation. Man, that's terrible.
That's a horrible one, but that is one of the best ones that people often miss. I have people who will come to me all the time and they say, I'm taking a bunch of medicine, I'm taking laxatives, I'm doing all this stuff and I can't go. And we check their thyroid and it doesn't work.
Yeah.
There's nothing you can take from a laxative or medication standpoint that's going to make you go if your thyroid doesn't work. You have to give something to get the thyroid working. So that is huge. And you just named 2 of the common ones that everybody knows. I'm tired, and I also have trouble with losing weight or gaining weight, one or the other. But constipation is a huge one, right? And that's why I'm happy we're talking about this, because sometimes people will come in and say, man, I don't understand why all these laxatives don't work. Well, something else is wrong. So this is when you're treating the symptom but not treating the problem.
Right.
That's why we need to get to the right diagnosis.
Constipation is awful, bro. I'd rather you sock me in the face than have constipation, bro. Like seriously.
So you want someone to sock you in the face rather than you have constipation?
Rather being constipated? Absolutely.
Okay.
Every day.
You must have had a traumatic experience. Dude, if that happened.
Well, I have some bad digestive history, but still.
No,
like,
I'm talking about as a kid, because that's the worst kind.
But even now, bro, like
yeah,
I will put Miralax in my coffee with the quickness. Like, I'm not doing it. I'm telling you, I'm not doing it.
You're never going back.
No, I'm not going back. I got to keep it moving.
Literally,
you got to keep it moving, bro.
So that is a huge part, and there's one more that is extremely important.
Well, mood changes.
Well,
like depression.
Depression, right? That's it. Correct. Depression. Some people don't realize that they feel down because their battery doesn't work. The battery in the body is not working, so your mood is going to be low.
Yeah.
And you're going to feel down. It makes perfect sense. the thyroid doesn't function, everything gets lower. Mood gets lower. The way your intestinal tract works slows down or gets lower. The function is lower. Your weight loss is lower, so you may gain weight. Your ability to have energy is lower, so everything's lower. So hypothyroid, lower functioning, pretty much everything. So let's go on the opposite, hyperthyroid. What are the symptoms that you tend to see in a person who has a overactive or hyperthyroid?
Weight loss, rapid heartbeat.
Okay.
Which is,
so let's back up. You say weight loss, right? So a person literally loses weight all the time when they're not even trying.
Yeah, because your metabolism is just rolling.
Everything's going overdrive, right? So food you're putting in gets burned up really quickly.
Right.
All right. You also said heart rate is going really fast, right? So the heart is being basically stimulated so quickly that it just starts to beat uncontrollably.
Yeah, and I'm pretty sure that can cause like heart disease and probably kill you.
Okay. We'll talk about that in a second.
Okay.
Let's keep going.
Sweating.
Okay.
Anxiety.
Okay. So let's go back. You just said the thyroid doesn't function, we're depressed, right? Thyroid functions too well, you feel
Anxious.
right? Now, why do you feel well, think about it.
Because your body's rolling.
Your body is literally getting stimulated all the time. Think about someone just tapping you on the forehead every 5 seconds, or if not, every 2 seconds. It just starts to get irritating. So you're going to be really overactively stimulated that everything is now in overdrive, including your anxiety level and your mood. So that's a huge one, all right? And there's one more that I want you to actually touch on. You said anxiety, you said fast heartbeat, you said weight loss. There's one more, well, sweating, yeah, that's okay. But there's one that a lot of people don't realize.
Difficulty sleeping.
Sleeping, right? Insomnia.
Yeah, you can't rest.
You can't rest. Your heart's going on overdrive.
Yeah.
You're jittery. You really and truthfully don't feel well, and you just don't sleep. So what is the common thing people like to do when they don't sleep? We had an episode on this. What is the first thing people do? I can't sleep. What do you think they do?
I don't know. Take meds.
Take medicine.
Yeah.
Take oh, I can't sleep. Let me just take medicine.
I take a shot.
Well, as long as it's a medicinal shot, let's say that. Joking.
I'm about to say whiskey's not medicinal.
If you're doing surgery out on the side of the road and you don't have nothing else, maybe it is, right?
Yeah, right.
That's antiseptic.
Yeah.
That's anesthesia.
Yeah, absolutely.
Everything.
It'll clean it out.
They'll clean everything, right?
Yeah.
But that's the idea. People will say, I don't feel well. I can't sleep. So let me just take medicine to put me to sleep. And you're potentially going to go to sleep. And then your heart is still just going in overdrive to where now you can't wake up when you need to. Your body's telling you, wake up, something's wrong. But you're medicating with heavy sleep medicine that you don't ever wake up. That's the unfortunate thing, because everybody wants to self-diagnose and self-treat. And that's unfortunate because treating symptoms is not always the answer. Sometimes treating symptoms are appropriate, but sometimes you got to get the diagnosis correct. And in this instance, you don't want to misdiagnose this.
No.
Not overdrive. Now, hypothyroid, maybe you can get by with it, right? Stuff not working as well, maybe you can function. But when it's in overdrive, you need to get it under control pretty quickly.
Yeah.
Right?
Because that can, this stuff can kill you.
Yep.
Like, I'm reading over what this is saying.
Yep, absolutely.
That's a problem.
It can absolutely do that. And there are plenty of causes for both things. Number one, the idea is not just your thyroid stops working on its own and there isn't a reason behind it. Now, if there is a reason, we want to get to the bottom of it. Sometimes it's different things, like your body is going to literally attack itself and do damage to the thyroid. That is the big category we call autoimmune disease. Autoimmune disease is a fancy way of saying your body attacks itself.
Yep.
And if your body is attacking itself, you're going to have problems with different things. So if the body attacks the thyroid for whatever reason, it can cause both problems. It can cause overstimulation in some instances, and then eventually it can burn the thyroid out and then cause understimulation where it doesn't function anymore. That's one specific disease that we will talk about. But the idea is that can happen where you start off with hyperthyroid and then eventually go hypo. So you have to be careful not to just think I can do this all by myself, and all of a sudden you misdiagnose, mistreat, mismanage, and have a pretty bad outcome, right? So I bring that to say we have kind of clarified the two biggest parts: hypo versus hyper, symptoms in the hypo category, symptoms in the hyper category. And when you have those things, you kind of start to put things together that I need to figure out how this is treated. So we'll pause for a second and do some housekeeping, because I don't think we did that as well. So if you're listening this far and you're enjoying yourself, please subscribe, please share, please rate, And please just give us some good feedback. We like positive comments. I think everybody does. And I think it's helpful for people to hear that, hey, man, I'm listening to this episode. I'm so far in, almost, I think, 30 minutes in by this point, and we're doing a good job of hopefully keeping your ear, but more importantly, you're learning. And if that's the case, tell other people about it. Share the episode. Give them the knowledge you're gaining so we can hopefully get more people engaged in care and get people feeling better. I think those are huge, important things. George, is there anything you want to add at this part of the episode, segue-wise? Because I know you're always working on stuff as well, and I don't want it to be where we're always just plugging our stuff. Anything that you want to share, at least at this point? If not, we can keep rolling.
Just Becnel Consulting for all your IT office needs.
There you go. There you go.
It won't. I'm not hard to find, so just let me know.
Hit my guy up. He's a free agent that is going to do great things. I already know that. But altogether, again, our purpose of this episode and all the other episodes that we're sharing is trying to spread knowledge, get people engaged in care, make it accessible. So
Thanks.
Definitely share information about the episode, share the radio show as a whole, and definitely keep us informed if there's anything we can talk about that would help you or help your family and the healthcare journey. So
you know what? I appreciate you shouting me out in the book.
Yeah.
That was good stuff,
of course,
man.
I had to talk about Patient Zero and how he literally is changing the game with this radio show by taking this journey with us, and more importantly, making it to where people can relate. And I'm not talking over people's heads, even though I think I'm saying stuff in a plane.
Yeah.
And you're like, nah, that ain't what that is. So,
That's what I'm here for. I gotta ask the follow-up questions.
There you go. As a good journalist would.
But I feel like the book was very just easy and it wasn't at too high of a level, but it was very informative.
Yeah, I absolutely positively tried to make sure when we wrote it, it was accessible, because I didn't want people to say, what is he talking about? I tried to make it as plain as possible. Yeah. That way it hopefully will withstand the test of time, that even if we don't put out any other follow-ups, it still is written in a way where it can basically last. It doesn't have to be like, well, we're talking about cassette tapes. And You're like, wait, what? So try to write it as simple and give analogies and examples that work. So thank you for, definitely talking about that, but more importantly, just being a part of it all from us building it brick by brick. I appreciate it. Yep. So moving into the final part of this episode. So we talked about the symptoms. We talked about the gland. We talked about what everything should do and how it functions if it's, in essence, not working the way it should. And we also talked about different things like prevalence and statistics. So we'll start talking about a few of the complex diseases that can come that may cause hyperthyroid and hypothyroid in one way or another. So there's the autoimmune category, and that's the category that a lot of people find when the thyroid doesn't work. And there are two diseases that tend to cause problems that we'll talk about. One versus the other do similar things. What they're doing is causing damage where your body is attacking itself. Mm-hmm. The cells and things in the body are literally coming up and saying to the thyroid, we want to cause damage to make it to where you don't function the way you should, or we're going to make it to where you're functioning semi the way you should, but not completely. So one of them, and the more common one, is something called Graves' disease. Okay? Graves' disease, cradle to the grave, Graves' disease is basically an autoimmune condition where things don't work, and I'm paraphrasing, and it causes hyperthyroidism. Hyperthyroidism, as we already talked about symptoms, you'll feel like you're having anxiety, you'll have a fast heartbeat, you're having trouble maintaining your weight, you're losing weight all the time even though you're really trying to put weight on, and it's just really wreaking havoc. But the reason it's happening is, again, you're having things in your actual body that are attacking the thyroid. And that's one thing that most people don't know about. Now, why is that important? Well, in Graves' disease diagnosis, sometimes that doesn't ever shut down. It's just going to keep on causing overstimulation of the thyroid, and it's just going to keep happening until you take medicine to cause the thyroid to calm down. So there are thyroid hormone medications that will literally shut the thyroid down. Most people would say, well, I've never thought about that. Yeah, you have medicine that you take that blocks the thyroid from working because it's now working too well. And in that case, you want a medicine that you will take as needed. And I say as needed doesn't mean take it when you want to, meaning as needed, like as someone prescribes it to you. But you want to do that in a way where it allows you to say, you know what, I want to calm this down enough to be able to function, but I don't want to shut it down completely. So that's one area of autoimmune disease. All right, so we talked about Graves and how Graves overstimulates.
So hold on.
Okay.
So basically, correct me if I'm wrong. You just mentioned about taking a medicine that helps control the thyroid. Is there anything that you can do about the autoimmune disease instead of like just attacking the source, right? Is there
a way to calm the autoimmune disease down? There are medicines that are pretty much being put out that may help to address the autoimmune portion, but nothing that's specific to just, in essence, shutting down the autoimmune portion for the thyroid. What I mean is, when you usually have autoimmune disease, you're giving medicines that shut down the immune system. Right? Let's take it out of the thyroid and Graves. Something like Crohn's disease. So Crohn's disease is a autoimmune disease where the body attacks the intestinal tract. So in Crohn's, you don't give a medicine that, for the most part, just goes to the intestinal tract and that's it. It kind of does things through the whole body. That's why a lot of people who have autoimmune diseases and take certain meds are more likely to get infections, more likely to get hospitalized with things like, bacterial infections, viral infections, fungal infections, because they don't have an immune system, because again, your immune system is in overdrive, and now we're shutting it down so it doesn't cause damage to your body. When we shut it down,
it's not doing what it's supposed to do either.
We're not, only able to shut it down in this area. In a perfect world, that's what the medicine we're trying to get. We're trying to get to where a medicine says, I'm only going to shut down the part of your body that's causing havoc, but the rest works fine. That's not quite there yet, but they're getting closer. And you can think about old medicine that may have been out compared to new medicine. It always gets better, and that's a good thing. So ultimately, there are medicines that will help calm the immune system down, but doesn't specifically say we're only going to work with the thyroid. Hopefully that makes sense.
No, it does make perfect sense, because we talked about controlling the problem and not just the symptoms.
Correct.
Right?
Correct.
So it just kind of sounded like we was only dealing with the thyroid, whereas in my mind, the initial problem was the autoimmune disease.
Correct. Yeah, and in a way, if you can address some of the autoimmune disease in one way or another, it will downstream affect the symptoms, right? Hey, I shut down the immune system. I'm not wreaking havoc on my intestinal tract or on my thyroid or on my skin. So now I'm not having as much anxiety or trouble with going to the bathroom and having diarrhea. Whatever the downstream effect is, usually those get better because the immune system is now shutting down. Not always, but a lot of times it does. So that's why a lot of times in Graves' disease, you will have us come in and say, we need to give you medicine to calm down the thyroid. We need to shut it down somewhat or all the way. And what we're doing is blocking the thyroid from being
damaged.
Not necessarily damaged, but blocking the thyroid from overworking itself. The way the thyroid works, it's a gland in the neck, but basically there's hormones that get produced from your pituitary gland in your brain that basically flow downstream to your neck, and then it tells your neck, make hormones. Those hormones then get put into your bloodstream and do stuff. That's the cascade, if you will. We didn't go into all the weeds, but that's the big picture. There's a gland in your neck, the pituitary gland, that puts out hormone that goes to the thyroid. It's called TSH, thyroid stimulating hormone. The TSH from the pituitary goes to the thyroid and says, make more thyroid hormone. The two thyroid hormones that usually get produced from the thyroid are called T3 and T4. T3 and T4 go into the body and do stuff. That's the way it works. So when your thyroid is in overdrive producing too much T3 and T4, you give you medicine that goes in and blocks the actual receptors so that the thyroid doesn't get stimulated by the TSH. That downstream effect, in essence, calms the thyroid down. It's not shutting the immune system down. It's just blocking the thyroid from basically being stimulated, right? Think about if you had a socket on the wall and you're trying to plug something into the socket. Well, we put something in the socket so nothing can get plugged into it. It doesn't get stimulated. You don't get electricity. It's the same concept. So the thyroid blockers are being given to block the thyroid from producing T3 and T4. So that's one option, right? Then, of course, the other option is just shutting the immune system down as a whole. Okay, so that's kind of Graves' disease, going into the weeds a little bit more.
Sure.
Right? There's another autoimmune disease that's a little bit more complex to explain, but the concept is very similar. The name of this one is Hashimoto's thyroiditis. All right. From your astute class that we had for the last episode, What is thyroiditis?
I would say inflammation in the thyroid.
Inflammation of the thyroid, right? Boom.
Bam.
Right? So itis, inflammation. So Hashimoto's thyroiditis is the inflamed thyroid caused by basically a disease process that is autoimmune related that causes long-term downstream hypothyroidism. In essence, it starts off as hyperthyroid. The thyroid is getting overstimulated so much that eventually it burns itself out. It burns itself out to where it's almost a way where it's self-limited is what we call it, meaning that the disease is going to kind of take care of itself. Now, the good news is that you don't have to worry about it being in overdrive forever, causing heart racing or palpitations, as we call it, causing anxiety, causing insomnia. What it is going to cause that for a time or two, and eventually it burns out to where you go into the opposite, low thyroid. Low thyroid, specifically depression, trouble with losing weight, feeling like you don't have energy, all of that. So Hashimoto's is very similar to a Graves', but eventually it burns itself out. And that's a second, more complex disease. And depending on when you catch this, when you kind of diagnose this, you'll see that this is something that is treatable, right?
So if it burns itself out, basically you could just manage the thyroid until it burns itself out, and then you're good to go.
You're good to go to an extent, but you may also go to the opposite, which we hadn't talked about yet, which was treatment for low thyroid, right? Because when the thyroid is in overdrive, you want to calm it down by blocking the receptors. When the thyroid stops producing hormone, you have to replace that hormone. Because remember, the battery doesn't make enough hormone. You can't just stop. You can go without it, but it doesn't really feel good. So you have to give synthetic thyroid hormone. Synthetic thyroid hormone, there's a bunch of different names, but the idea is it's basically manufactured thyroid hormone because your body doesn't make it anymore and you can't eat thyroid hormone. It's not made in nature. So you have to basically get synthetic thyroid hormone to replace it or supplement, right? So that is the other side, right? The thyroid is going too fast. You start causing the blockage to try to maintain it working on its own as long as possible. But eventually if it burns out, it burns out. Then you flip to the other side and give it thyroid replacement. So that's the treatment of low thyroid versus hyper or high thyroid. So that's your two basic concepts, okay? There's one more that I have to highlight, and this is taking us all the way back to the beginning of the episode. There's one more disease that I'm gonna let you at least give the people a definition of what it is, because I have to tell this story because it's actually happened to a patient of mine. So go ahead and read the last one that we want. So we talked about Hashimoto's. We talked about Graves'. So what's the last one you're going to talk about?
It's a thyroid storm.
Okay.
That sounds terrible.
It sounds terrible. Or it sounds pretty cool if you're an X-Man fan.
Yeah, I think hurricane, so I'm going to say it sounds terrible.
So Storm was the truth. Let's start there.
Storm was the truth.
Okay.
But I was watching ESPN back then instead of like cartoons.
Okay. Well,
Don't judge me.
shame on you, because I was a super X-Man guy. Gambit was my guy, first and foremost. Huge X-Man fan. Who was Gambit? No idea.
No idea.
Okay. Where was Gambit from? Take a guess.
Home of Louisiana.
He's from Louisiana. That's the first thing.
Cool.
All right. Any idea what his nickname is? I'm gonna give you a hint. James Carville.
Oh, the Raging Cajun.
Raging Cages. So Gambit, the original X-Men from Louisiana, who actually talked like people from down the bayou. He would say Cher and Mon Ami and all this other stuff.
That's cool.
That's crazy, right? So Stan Lee is a genius. Whole nother conversation. But anyways.
I had no idea what that was.
Yeah. Well, that's what I'm here for. I'm educating you not only on health, but also on comic books.
Yeah, I was Ninja Turtles, Ghostbusters, and then after that I went straight to Stuart Scott.
Most famous Ghostbuster.
Most famous Ghostbuster? I would say Peter Venkman.
It's Egon, actually.
Egon? No.
Egon. No.
He's not the most famous.
I didn't say coolest. I said famous.
No.
Okay.
He's not.
Okay. Who are the other two?
Winston and Ray.
Okay. So most people know the names, but most people can remember Egon and what he looks like and everything else.
Just because he had glasses.
Exactly. That's why he's the most famous. Right?
He just had glasses.
Hey, he's a very memorable character. Plus, he was the nerd, and
He
I
was the
identify with the nerd. So, all that being said, getting back to the most important part, thyroid storm.
All right.
What is thyroid storm, my friend? Go ahead and give the people.
It's a form of hypothyroidism that's is actually life-threatening.
Okay.
Symptoms are fever, rapid heart rate, mental confusion, and you need to, if you start feeling those things, you need to get to the doctor,
Okay.
like ASAP.
So I got to paint a picture, and I want you to bear with me. It's going to be a lengthy description, but not overly lengthy. I'm going to do
Okay.
my best to kind of bring it home. Young lady comes to see us
Alrighty.
at what we call an FQHC. An FQHC is a federally qualified health center. Basically, it's the underserved clinics where patients who don't have insurance get care.
So it's before you started here.
That's before I started here.
All right.
So I worked at an FQHC. I was in New Orleans on the West Bank. I would work, and fun fact, for anybody who's just starting to listen, as I was building this clinic, I was driving back and forth to New Orleans 2 times a week to literally build this practice and still pay bills. So if you're listening to this, the motivational piece to that is don't let anybody tell you you can't do something, because patients didn't just show up when we started opening. We had to literally go out and grind. And if I'm driving an hour back and forth 2
All the way
times
to
a
the
week,
West Bank?
all the way to the West Bank 2 times a week, while seeing patients here and seeing patients there and taking care of the underserved, I don't know what the excuse is other than you got to want it.
Right.
Right.
That's a hell of a drive. And also, I wish you'd told me you was on the West Bank, man. I'd have met you at Caesars, man. we could have a good time.
I would never be in such an establishment, sir. Sir,
What's wrong with Caesars?
sir. This is a family show, is all I'm saying.
It ain't, ain't nothing but a little male waiters in Caesars.
There you go. There you go.
A little hole in the wall. Found love on a lonely highway. That's
That antiseptic that you were talking about earlier.
yeah,
right?
man. And that antiseptic.
You're right. Ain't nothing wrong with that.
So it was a good time.
So I was at the FQHC working on the West Bank, and this patient who I've been seeing for a little while, because I worked there for at least a year and some change, came in and basically said she was having trouble, but didn't really know what it was. Okay.
Sure.
When she said trouble, she said she felt anxious all the time and she was having trouble sleeping. Okay. So we're having a conversation, we're talking, and I'm literally doing my full trying to like go through and do this. Now, mind you, in the FQHC world, visits are short, 15, 20 minutes. So I'm doing as much as I can, and I literally take my stethoscope, go and examine her, and I listen to her heart. And our heart is beating so fast. Now, most people, if you know anything about a heart rate normal is between 80 to 100. Okay. When we say there are palpitations, which means your heart is going fast, her heart rate, because I had a stethoscope that literally allows you to listen, but it tells you the heart rate on the stethoscope. You know how fast her heart was going? 180.
Wow.
180. Her heart was beating that fast. And then on top of beating 180, it was skipping beats. So normally when your heart beats, it's the boom, 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 boom. So hers is beating really fast, but it would go boom, 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 boom. It was jumping around. So it's going fast, but it's also irregular.
So
And
she
there's
was at risk for like a stroke or heart attack?
Absolutely. So there's a certain diagnosis of what this is called, and you'll see the commercials all the time. If you're a medical person, especially on the medical side, the catchphrase we will say is the heartbeat was irregularly irregular. And if that term is ever uttered in medicine, that means somebody has something called atrial fibrillation or AFib.
Yep, I've heard that.
AFib is a cardinal diagnosis that causes strokes.
Yeah.
The heart is beating so fast that it throws a clot and it goes to your brain. So she's coming in with no insurance, okay? None. Heart is beating crazily and it's irregular. And the first person to hear it is me, because she had no medical care, right? So we put her on the table and do an EKG, and it confirms she has AFib. So I tell her, your heart is beating so fast, we have to try to slow this down. But I can't slow it down with oral medicine because it's going to take too long. So you need to go to the hospital, okay? What do you think the issue is?
She doesn't have insurance. She also probably doesn't have a ride.
Didn't have a ride. So what do you think we have to do?
You have to bring her to the hospital?
Bring her to the hospital. Load her in the car to bring her to the hospital. Because I don't like patients dying on my watch. I don't know about a lot of people.
And I guess calling an ambulance was taking too long.
Well, you can call an ambulance. It just depends on how fast will they get there. Because believe it or not, it's not TB.
Yeah, you're in the West Bank.
You're in a place where it's hard to get
Yeah,
to.
it's underserved.
Right? It's
Yeah.
underserved, right? So basically, we get the lady to the hospital. And what do you think the lady has?
AFib.
AFib. We already confirmed that, right? We did the thing.
What time she had a stroke?
She had a thyroid storm.
Oh, God.
She literally, they drew her blood and they checked her and they basically calmed her heart down, all that. Happy ending, she's fine.
Yeah.
But
All right.
but they literally pulled her thyroid because her heart was going that fast. And it just didn't make sense because she has no medical history, no reason to have AFib, and she's a young lady. Remember, who's more likely to get thyroid problems?
A lady?
Female, right?
No Adam's apple.
So because of that, they check her thyroid hormone, T3 and T4, and it's through the roof. So she's in thyroid storm that caused her to have fast heartbeat, anxiety, trouble sleeping, irregular heartbeat, and then, of course, AFib. So when she comes back to see me, of course, she's super nice. She's super thankful. She's basically saying, you saved my life and all that. And I'm like, I just did what I was supposed to do. But it's one of those things I could have easily said, I only got 15 minutes. Be quick. But it's taking in those 15 minutes, stopping and saying, you know what? Something's not right. We need to get this right. So that young lady on that day with that 15-minute slot, she was in the clinic for an hour. Because I told her, you need to stay, and I'm going to do whatever I can to make sure we get this right, because I don't want you to walk out of here and not ever come back. So the point is, thyroid storm happens all the time, but people ignore it. Well, I'm just tired because I didn't sleep last night.
Yeah.
I just need to take some more medicine to help me get some sleep.
Sure.
I just need to really and truthfully try to figure out a way to calm down. Because, I'm drinking too much caffeine. That's why my heart's racing, right? I just got to stop drinking caffeine and it's going to go away. And you don't realize your thyroid's not checked. You're out of the normal range and it's going in one direction or another. Because, again, Graves can cause that feeling. Thyroid storm is like the Graves on steroids is the best way to say it. It's really bad. And if you're in thyroid storm, it is a medical emergency. Hence why she had to go to the hospital.
Sure.
Right? It's not let me think about it. Let me go home and I'll come back tomorrow. It's you going to the hospital one way or another.
Yep.
And that's the whole point. So all that being said, the idea of thyroid storm is one thing that if you have any thought that this could be you're listening to this episode and someone has these issues and they're just ignoring it, get them to a hospital or to a clinic as soon as possible and make sure they're getting checked and getting treated, because there are plenty of medicines that can be used to calm these things down and get it under control, and also make sure people live long, healthy, happy lives. So that's the long-winded, very, very, in my opinion, happy story, but it's always something I'll always remember.
So, question.
Yes.
How did this experience, really sit down, really make you think this model isn't working? Or were you already convinced that the model wasn't working? Or did this experience kind of push you over the top? Where were you mentally after that?
Well, I was already doing the direct primary care model, and I'm doing the extra work to help
you pay the bills until you get off the ground.
To get off the ground.
So it was just confirmation.
It's confirmation because, again, these patients need good care too.
Yeah.
People with no insurance need the same type of doctor who's going to literally do what I did. And it shouldn't be that they're penalized for not having insurance. You don't have insurance, so you get a doctor. If you literally have problems, that shouldn't make sense. That shouldn't make sense to a person that says, I have a really bad insurance plan or no insurance plan, so I'm not going to get really good care. You want a person who's going to say, you know what, I really and truthfully deserve good care, and I need a way to access good care. And if this person provides me with good care, I'm willing to meet them in the middle.
Right.
If meeting them in the middle is paying an affordable monthly fee, then why not? And most people are willing to do that. It's just that a lot of people don't know it exists. And that confirmed that in the model, if she was with us, not at the FQHC, we wouldn't have had to worry about her being rushed. We wouldn't have had to worry about her getting misdiagnosed and having to possibly come back, or even worse, sitting in the waiting room and not actually having the opportunity to be seen because there's so many people, she just leaves.
Right.
So for us, we're one in, one out, an hour long with each patient, and it gives us the opportunity to do that. And this just emphasized that even though she didn't have insurance, she would still get the same care whether or not she does or she doesn't. So to answer your question, I think it confirmed what I already knew, and it just made me happy that I was in that space at that time. And I hope that those patients continue to do well. But again, if they don't, and it's because their insurance is not, quote unquote, the big good insurance, as most people will say, I got good insurance, then that doesn't make sense to me. All things considered, we're doing great work over here. I know we are.
Absolutely.
So with that, I think we're at time, my friend. I think we're getting close to almost the hour mark. So this is a pretty normal episode compared to our gratitude episode a couple weeks ago,
which was
the abbreviated
pretty
episode.
short.
So based off of this, I think we're going to start to wrap up. So anything you want to add, anything that you want to take home from today's
Sure.
episode that
So-
you say, you know what, this is important. I think this is something I think people need to.
Normally I have a statement, but I have another question.
Go ahead. Go ahead. I'm sorry if I'm cutting off the questions. I just don't want people to be like, man, he's really going in on this story. But if there are questions, I'm all for it.
Patient zero has a question.
Patient zero has the question. What is the question of patient zero?
So I just, you talked about, providing healthcare for people with, without insurance, and you're doing excellent work here. Mm-hmm. You talked about that clinic you were at previously that was taking care of the underserved community. So what are you doing here to help take care of the underserved community who may not have the membership fee funds or what have you?
So we're trying to find ways to make that accessible as well. So we started a nonprofit, and people have heard us talk about it, but to give more context, the nonprofit is called the Byja Charitable Alliance. That is a nonprofit that people can donate to, whether you're a patient or not. You just want to help people get good care, and that patient donation will hopefully be something that patients will say, you know what, I really appreciate this nonprofit because they're allowing me to get access to this model that otherwise I wouldn't have access to. We're doing a patient assistance program where we are helping to cover some of the membership cost for a patient, or we're covering all of the membership costs for a patient who meets financial criteria. On top of that, we're also setting up different referral partners that will allow patients to get access to affordable services in industries they otherwise wouldn't have access to. Things like mental health, things like nutritional education, things like financial planning and financial advising. All of that is accessible at a very low affordable rate that otherwise people would have to spend thousands of dollars to possibly get access to without insurance. So we're making all of this transparent and affordable. We tell you how much everything costs up front. There's no mystery. So if you're an employer and you say, I want to know how much it would cost to cover my employees, we can tell you that. There's no, well, it depends on your network and it depends on what the diagnosis is. We just tell you how much it costs. And the same thing goes for these patients. If they want to know how much it costs for them to get care, we're going to literally do the math and tell them. And once the math is there, it's up to us to find a way to make it work on both sides. And I think a lot of people like that. And we've so far been able to successfully get several people enrolled in the patient assistance program who otherwise wouldn't have access to this model because they don't have the means, but they gave us an opportunity to care for them. So we're going to do our best and find a way to get them the care they need.
Hey, that's good stuff, Doc.
Thank you, brother. I appreciate it, man. So let's go into our wrap up for this episode.
Sure.
A great episode, I would say. I think we educated quite a bit of people. I think we also have people potentially coming in saying, you know what? I never thought about this, but now that you all talked about it the way you did, I feel confident that I know we can have somewhat a dialogue of, let me talk to my doctor about the thyroid and what it could be. So, George, I'm going to kick it to you first. What things are your take-home points for today's episode about thyroid health, hyperthyroid, hypothyroid, anything in general, things that you want to take home for people to say, you know what, let me sit with this. I'm glad this point was made.
I would just say pay attention to your energy levels, how you feel, your overall health. Mm-hmm. And if something seems abnormal, don't just attribute it to you getting a little older or you just saying it'll fix itself. I challenge you to check it out. And also challenge your doctors as well. Like if you're not satisfied with what you're hearing, or if you're not satisfied with, or if you're not 100% sure, or you don't have 100% confidence in what you're being told or your plan of treatment, I would say something and ask more questions and follow up, because your health is ultimately your responsibility, not your doctor's. So, Dr. Jasper is a good friend of mine. He's my doctor. I have 100% trust in him. But when we're talking about things, I ask follow-up questions and I make sure that I'm 100% satisfied and I'm 100% aware of the plan of care and going forward. So my two things is, if you notice something different, say something. Don't just sit on it. And two, ask questions and be 100% confident in the plan of care and ask questions and have dialogue until you are.
I will kind of follow up on one of the things you said of being okay to challenge the doctor. A lot of people have a very interesting approach to how that works. What I mean by that is I've had people literally sit there and it's all one way or the other. It's all adversarial. Everything is a challenge to where there isn't a really good relationship. Yeah. And yet they keep going back even though the doctor and them don't see eye to eye. Mm-hmm. The other thing is you just sit there and let the doctor tell you anything and you never ask questions. Yeah. And I'll give a quick example. When I have patients sit down with me for the first time and I say, did they do this test? And the first thing patients will say is, yes, they did it, and it was normal. And my first question is, well, what is normal? Mm-hmm. And if we're talking about simple things, well, my kidney stuff was normal. Okay, I'm not going to possibly harp on that. But if it's your A1C or your cholesterol or your thyroid, well, what does normal mean, right? So that conversation has to happen where you're willing to give that challenge to a doctor or your medical team and say, tell me what is normal and what's abnormal. Tell me how close I am to being abnormal, and tell me what is necessary to maintain this level of normalcy. If you can do that, that literally makes you a better patient, and it makes you more likely to have better health outcomes. But you can't do that if you don't have the conversation and make sure that you're being involved in the actual healthcare plan rather than just sitting there, being quiet, saying yes, saying yes, saying yes, and then you walk out and then have no idea what just happened.
Yep.
So you have to do both. You have to be engaged, you have to have dialogue, but you also have to be willing to challenge and ask questions when other people are not quite there. So all of that being said, I think we're kind of at a point where we can slowly but surely wrap up. So hopefully this episode's been helpful. If it has, again, hit the like button, subscribe, share, give us some positive comments, and hopefully we can get this thing going and catching more momentum. Again, we're in the saddle at this point. We're at a point where we're slowly but surely going to do the things we need to do to put out good content regularly. Mm-hmm. And that way people can kind of start to rely on us being a trusted source of journalism, with Patient Zero being clearly the lead anchor, and I'm just here as the sportscaster and the weather.
Yeah, I'm the third Gumble brother at this point. You know.
What is your name? Are you George Gumble?
Sure, why not?
I could actually see it. I could see it.
Yeah, I just need like a funny 80s haircut, you know, and I'll be straight. I'll be good to go.
There you go. So are we going with a funny 80s haircut right out the gate, or are we going to slowly but surely get to the 80s haircut? Because they at one point didn't have funny's 80s haircuts. They had regular haircuts, and then obviously when you get to the 90s and the 2000s.
Yeah, but I'm gonna start out with the funny.
You're just going straight, okay?
And a sport coat.
Okay, you got to have a sport coat.
Gotta have a sport coat.
Can't be a Gumble brother without a sport coat.
No.
So I get that. So George Gumble, the trusted journalist that you are coming to know and love, is clearly taking us to higher horizons. But we need you to like, subscribe, share, and do things that will help us get to that next level. Other things, I'll do a quick plug. If you haven't already, please consider going out getting the Byja Blueprint book. It is our book that is giving the introduction to direct primary care for patients, for physicians, and also for businesses. So the goal is to really give you that intro into DPC and what it could be and how it works and why is it so successful for a lot of people, and basically changing the way healthcare is delivered. So if you haven't done that, it is available in multiple platforms. It is available on Amazon, Barnes & Noble. It's also available on ebook platforms. Mm-hmm. And of course, we would love for you to do your due diligence of getting that, reading it, sharing, commenting, giving us positive reviews, because again, our goal is to get the word out more and spread the news of DPC. With all that being said, we will slowly but surely 100% close out. George, where can the people find you?
On Elon Musk's Twitter X thing, it's George_Becnel. Instagram is at Becnel Media. Like I said, I'm not hard to find. I don't have any social media for Becnel Consulting yet, but I'm pretty sure that's going to come very, very shortly. But either way, you can find me on those two platforms.
You also forgot to tell them that George Gumble is the new actual social media handle that you're about to get at this point.
Yeah, man, so, why not?
There you go.
I'll probably call it third Gumble Bro. You know,
I'm not arguing. I think that's
I think that's a good one, man. I gotta wear sport coats without any vents in them.
Yeah.
And really be like traditional.
If we're doing a play on it, you could be 3GB, which clearly works anyway.
Oh my God,
that's amazing, right? See?
Yeah.
Stick with me, kid.
Let's do it.
Yeah. So the third Gumble brother will be coming on one social media handle, one way or another. We'll let you know when that happens.
Yes.
As for us, you can find us on social media at Facebook and at Instagram. It is at Byja Clinic, all one word. You also can find us on our website, www.byja.org. That is Byja Clinic's website. And we're also on LinkedIn under Byja Clinic. For the Charitable Alliance, the nonprofit, that if you want to learn more about who we are, what we do, and possibly donate, that is www.byjaca.org. And then, of course, Byja Radio is here, and the Byja Blueprint book is out. So all of that we will close out today. We thank you for listening this far, and we are looking forward to having you check us out on the next episode. We'll see you when we see you.